Hi, good afternoon. Dr. Mangoba here. I'm doing a follow-up video on the COVID-19 that I did 6 to 8 weeks ago. So what I actually want to do today is I just wanted to give a summary of some of the findings that we have, what we know, and then we'll just jump into some questions and answers. So hopefully someone out there gets something from what I'm saying. Some of it may make sense, some may not, but I'm hoping I'm as clear as I can be. So we're just going to jump into the talk. Risk factors. So after having 3 months of experience caring for patients with COVID-19 as a nation, there are certain risk factors that we are fully aware of that put you at actually higher risk for actually getting severe illness. So we're talking about severe illness, not just getting COVID in general. So those individuals who are more likely to require hospital care, these are some of the things that they have in common. So if you're 65 or older, you're at higher risk. We can probably drop that age to maybe even 50 years or older. But if you just take the 65 and older demographic, they probably represent close to like 60% of those that are actually being hospitalized for severe illness. So very significant. Another risk factor we see is high blood pressure. So about maybe 65% again of those individuals who actually have severe disease have high blood pressure. And there's no mention whether they're controlled or not controlled. I think just having high blood pressure in general puts you at risk. And we have some science behind that. I can go into it, but probably not up front. If one of the questions come up, maybe we'll discuss it. If you're actually obese, that puts you at risk. So about 55 to 60% of those with severe illness probably have obesity. And we define obesity here in the States as having a BMI of 30 or above. And so you can plug in your height, plug in your weight, and we can calculate this number. But 30 or above for a BMI puts you at obese category. That in itself puts you at higher risk for having severe COVID-19 disease. Diabetes is another health condition that again puts you at risk. Okay. 3 things that you can't change. If you're African American, we're finding that more than 60% of actually severe illnesses and I think even mortality, we're looking at like 40 or 50% of them are African American. So they represent less than 50%, maybe even 20% of our population, but they're representing more than half of the severe illnesses and hospitalizations as well as deaths. So very significant risk factor. Hispanic ethnicity also puts you at higher risk. They also have a higher percentage of hospitalizations and severe disease, not proportional to their percentage in the general population. And then lastly, being men or male. They represent about 60% of severe hospitalizations, as well as I think they make up more than also 50 to 55% of mortality. Okay, so those are the risk factors. Some of those you can modify, some you can't. If you can modify them, certainly you should do everything you can to address those. So diabetes, blood pressure, weight are kind of the 3 big risk factors that are modifiable. Okay, so I think this is a very valid question that we need to address, and a lot of people are asking, how contagious is it? So you're going to hear some terminology out in the media. There's a term called R0, which actually defines how many individuals one infected person will get sick with the virus. And so the higher the number, the higher the contagiousness. So like if it has an R0 of 1, for example, that means that one sick person will only get one other person sick. Okay, so that's 1. If you have an R0 of 2, one person that is sick will get, or let's just say not sick, infected. One person that's infected will infect two other persons. Okay, so the higher the R naught, the more persons it will infect for every one person that actually is infected. Okay, that number is actually, it's not set in stone. There's a lot of factors that determine how contagious these agents can be. And so some of the more common factors that contribute to how contagious any infectious agent can be, whether it's the coronavirus or the flu or the common colds, population density is like the biggest factor. Okay, if there's no other person near you, they're not going to get anybody else sick, or you're not likely to get sick. And so areas like New York City specifically, Los Angeles, those two cities for their respective states have actually had the highest infection rates. And if you actually look at the population density in those two cities, it explains why they're the highest. Okay. Hygienic practices. So there's a lot of cultural norms and behaviors in terms of personal space, how we greet each other, things of those nature, and the cultural and social norms that permit for a closer proximity to each other, those will tend to allow for a higher infectivity rate. Okay. And then one of the things that you may or may not have heard of is something called herd immunity. Very important. Really, what herd immunity tells us is in a given population, so in this case, the worldwide population, we consider that whole population as the herd. And the more people in that population that are immune to the infectious agent, the less infective the agent will become. So, for example, the flu and the common colds, a lot of us have been exposed to that at one point or another. So each of us have, to some degree, various levels of immunity against the flu and the common colds. And that in itself will help, number one, protect us individually from getting the infection, but it also helps minimize how fast an infection will spread within the community, because if the virus comes to somebody that's immune, that person is not likely to get sick and not likely to become infectious. Therefore, the virus is stopped in its track whenever it lands on somebody who has immunity against it and is not likely to develop symptoms of an illness. Okay, so in comparison, everybody's comparing these to the common colds or the flu. So, and it's reasonable to do so because the novel coronavirus causing COVID-19 is related to the coronaviruses that cause the common flu. So it's reasonable to kind of make comparisons. So it's kind of early to make a hard statement, but I think we know enough that if all factors are the same, okay, so all factors being the same, meaning at a point in time in our future when we have just as many people who have immunity to COVID-19, at that point in time, when we have an equal amount of herd immunity, treatments, and vaccines potentially, we know I'm fairly certain, and I think it's accepted by most of the experts, that the COVID-19, the novel coronavirus that causes it, is probably going to be just as contagious or slightly less so than the ones that cause the common colds. And it's not unreasonable to believe that because it is related to the coronaviruses that cause the common colds. So the next step is in comparison to the flu. So all factors being the same, we will most likely see that the novel coronavirus will be more contagious than the common flu. Okay, will be more contagious. And the reason for that is the coronavirus that causes COVID-19 is, again, related to the coronaviruses that cause the common flu. And we know that the common flu is more rampant than the flu. The common cold is more rampant than the flu. And therefore, this COVID-19 is probably going to be more likely to be more contagious than the flu. We already know that it is currently, but the reason it's more contagious now, I believe, mostly is because there is no herd immunity and there is no treatment. And it's new, it's novel, and therefore any person on this planet who gets exposed to it has the potential to have some type of infection and illness, which will likely contribute to them spreading the virus to somebody else. Okay, so how contagious is it? More likely to be more contagious than the common flu, and as contagious as the common colds. Okay, so contagiousness and fatality are two different things. They're related, but they're not the same. So how fatal is it? So how likely are you to die if you get infected with the novel coronavirus? So various factors, again, affect the mortality rate. Host immunity. So are you immune? Have you been exposed to it before, developed antibodies against it, and therefore have some degree of protection to the reinfection or re-exposure to the coronavirus? So that's one factor. Herd immunity. How much of our world population, or and for us, how much of our state population or our county population have immunity against it? Again, the more people that have immunity against it, the less likely you are to get infected. And that means that less infections, less deaths. Okay. Medications available to treat complications related to the infection. If those are readily available and proven to be effective, that can reduce the mortality. And then vaccines being available will also help with host immunity as well as herd immunity. So once we have the vaccines, it's going to reduce the fatality rates that is associated with the COVID-19 infection. So all factors being the same. So if all factors are the same, so I'm going to say if, maybe I should have said when, because I think we'll get there. When all factors are the same, meaning we have treatments for the COVID-19 disease, we have vaccines for the COVID-19 disease, and we have herd immunity for the COVID-19 disease. I think at that point in time, the COVID-19 novel coronavirus will still be more deadly than the common colds. Okay, you don't die from common colds. We'll still see some deaths with the coronavirus and COVID-19, but I think in relation to the flu, so all factors being the same, it being the COVID-19 is probably going to be less deadly than the flu. Okay, and the reason I can say that is with the flu, we already have vaccines, we already have proven effective treatments, and we know that we have herd immunity because it goes around the globe. Okay, every year it comes and goes. And despite having all of those, guess what? We're still seeing, this year the CDC estimates we're going to see about 30 to 60,000 deaths in the United States alone just from the flu. Okay, so yes, a number of deaths from COVID are already far higher than that, but we have to realize that it's new, and at some point it's no longer going to be new, it's no longer going to be novel, and when the dust settles, when we have everything else available that we have for the flu, I believe that the COVID-19 will have a fatality rate that's actually going to be far less than what we're actually seeing now, and it will actually be less than what we typically see on a mild flu season. Okay. All right. So now testing. Just to summarize, there's two tests that are available for the COVID-19. The information that we get is different from each. So the first test that came out was the PCR testing. Okay, the PCR testing is what we call a nasopharyngeal swab, and it actually detects or looks for the presence of the viral RNA. Okay, so if a positive test comes back for a PCR test, what that tells me is that the person who got tested has the virus. Whether the person is sick with symptoms or whether the person is asymptomatic, we cannot say. However, what we do know is that individuals who are most likely to be the most infectious, okay, so they have a high amount of viral particles that they're shedding, those individuals tend to be the ones who actually do get sick and they do have symptoms, but they tend to be most contagious 2 to 3 days before they actually present with symptoms. Okay, so the initial thought was it can be up to 2 weeks of incubation where a person can actually be infectious. Probably still the case, but the general rule that we're seeing now is probably 2 to 3 days before a person actually comes down with some significant symptoms is when they're actually the most contagious, and they're usually the ones that are the most contagious. Okay, so it would be good to know when we do the test, after you got the test, if it was positive, was it after you got your symptoms, before you got your symptoms, or without any symptoms? And then also, if you do have symptoms, when did you have your symptoms after your positive test? That will kind of tell us which time window we're looking at in terms of your infectivity and your potential to have exposed other people to the COVID-19 in the course of your work or your daily interactions. So the other test that has been made available is the antibody testing, or serology test is actually what it's called. So this is a blood specimen. You actually get your blood taken, and they actually look at your blood plasma to see if you have antibodies for the COVID-19. We know that antibodies result as a recovery from or even just having an infection. Right now, we're not sure if the antibodies from the COVID-19 will result in lifelong immunity or it's going to be a short-term immunity like we see with the colds or the flu. We don't know. That big question will determine how the vaccine will be developed, okay? Because we can have one generation of vaccines that come out pretty quickly, which some say reasonably maybe by the end of the year or early next year. But we don't know whether that's going to be effective against the emerging strains with the COVID-19. And if the COVID-19 behaves somewhat similar to the flu, where every year it kind of changes its makeup, then the vaccine that will come out later this year or early next year may not be as effective for those who receive it moving forward. So it's a big question. We don't know, but so what the serology test will tell us is, have you in the past been exposed to the virus? And that will pretty much be what it will tell us. And so this is a good way to maybe test for people who never actually got sick or had no infections, but potentially were exposed to somebody with COVID-19. If we did a swab on you and you're not having any symptoms, you may turn out negative, but doesn't tell you much about your history of exposure. So if you're concerned about having been exposed or curious about it, the test for you is not the PCR testing, it's actually the serology test, okay? The serology test will be able to pick up antibodies as early as about 7 to 10 days after you've been exposed or infected. And so if you get the test too soon after your illness, it may not show up. And so it's a matter of waiting a reasonable amount of time to test to see if you have antibodies, because the body can take as long as maybe 2 to 3 days to create one type of antibody when you're first exposed and infected, and then it may take another 2 to 4 weeks to produce a different type of antibodies that will result in longer immunity. And so we're looking at a period of 1 to 4 weeks potentially before it may even show up positive. All right. So, what do we know of the infections in terms of severity? The numbers that we had kind of initially thrown out when the first cases came about has actually held true. So about 80% of cases are actually mild or asymptomatic. 15% of cases are severe enough that requires hospitalization. And then 5% of the infections are critical that requires them to be placed in the ICU setting. Now, ICU setting or critical care does not necessarily mean the vent. Okay, you can be in the ICU because you need medications to help support your blood pressure, or you may be getting other medications through multiple IV lines. There's various reasons to be in the ICU, and not all of them require ventilation. Okay, so I think the actual ventilation rate for most people or most countries, I think, is we're looking at maybe around 2 to 3% or even less of the people that actually have infection actually require the vent at even any point in time. So it's far less than the 5% that requires some type of critical care during their hospital stay for treatment. Okay, so here's a big question which we didn't really touch on it on the first talk, and I think it's because we didn't really have as much information available. So how does it actually cause illness, okay? And how does it actually kill people? Well, the virus itself will eventually kill the cell that the virus infects, okay? So when the virus infects you, it actually can get in through your nose, through your mouth, eventually goes into your throat and your lungs. So that's where we suspect most of the infections are occurring. When you breathe in and it gets into your lungs, the virus attaches to the cells that line your lungs. Okay, they get inside, they hijack the machinery of the cells, and they cause the cell to actually clone the virus that got in and produce millions and millions and millions of copies. And then at some point, those viruses will break through the cell membrane, kill the cell, and then that cell releases a bunch more of viral copies that will infect other cells. So that process of viral replication and viral shedding will kill the lung cells that and other cells eventually that get exposed to it. But the number of those cells that are potentially exposed is not enough to explain the damage that we're actually seeing in people that have severe cases of the COVID-19. So how does it actually cause what we're seeing? Well, really the biggest mechanical or process by which it actually initiates tissue damage and organ damage. Okay, so tissue and organs. So we're talking about organs would be lungs, heart, kidneys, liver. The biggest reason why it causes problems and damage to multiple organs is the virus in some way has an impact on the immune system. It disrupts one of the control mechanisms, or various control mechanisms, we think, that regulate your immune system and regulate inflammation inside the body. And so when we actually look at the people that die from multiple organ failure related to COVID-19, a lot of it is actually due to the body itself. The immune system plays a big part in inflammation, and it's the immune system that's actually activated and then uncontrolled. And when it's uncontrolled and activated, it actually attacks your own body. So a lot of the processes that normally are under control are actually uncontrolled and in higher volume or higher intensity of activity, which leads to the actual organ damage and organ failure. So that's how it kills us. Okay, so really the culprit is our immune system, because it's the actual agent that causes the harm. Although one can argue that it's the virus that kind of blinds the immune system, and then the immune system is just attacking willy-nilly what it can attack. So the cause is the virus, but the agent that causes the actual death is our immune system. Let me see here. Let me postpone this for longer. I keep having to do this. All right. So available treatment. So after kind of 3 months of experience with this, we now have several available options to kind of treat the individuals with severe disease, and hopefully moving forward have a lower fatality or mortality rate. So one of the biggest that's recently available is convalescent plasma infusion. What does that mean? Well, so the individuals who have COVID-19 and recover from it have antibodies. Antibodies are in your plasma. And so what we can do is we can request that those who have recovered from COVID-19, when they're healthy enough, donate blood at the blood centers, and the blood donation centers will actually spin your blood, and they don't waste anything. They take white blood cells, they take red blood cells, they take platelets, they take plasma. Those are the components that come from whole blood. And so the plasma is actually rich in antibodies, and we can infuse small amounts of the antibodies to individuals with really severe disease, and we've seen that it actually helps reverse their downward course and reduces the mortality related to the infection. So if you can cut the virus replication quickly early, then you can allow for the immune system to kind of get back under control. You have less overactivation of the immune system. So a bunch of other beneficial things with the antibodies. So that's one that's very available and has been shown to work. There's a drug, remdesivir. It's still actually considered experimental. It hasn't been approved for regular use, but it was actually developed 2 or 3 years ago, or maybe a little bit shorter, to treat Ebola. And in that regard, it actually hasn't gone through the usual process of ensuring its effectiveness and safety with Ebola. But because it was available and we're at a desperate time, it was actually experimentally tried in some individuals, shown to have some benefit, and so the FDA actually approved a study of around maybe 400 or 500 patients where they systematically gave it, and they found that at the very least, the remdesivir allowed for recovery of those with severe illness, I think for at least 2 or 3 days, if not longer. Now, the drug manufacturer and the study organizers were wanting to potentially extend it longer, but the FDA cut it short. And so that was a disappointment for a lot of us in the medical community, because we don't just want to find something that's going to make your symptom shorter. We actually want to find something that can potentially reduce and prove it, reduce the amount of fatalities related to this infection. But the FDA felt that it was not ethical to withhold treatment that has been shown to reduce how severe and how long your disease condition is. And so they terminated the study a little bit early without allowing it to go further, in the hopes of trying to see if we can prove that it actually reduces mortality. All right, so that's remdesivir. Hydroxychloroquine, I think we mentioned that earlier on. It's also still being used, although we're not quite sure how much benefit it has, but it's been one part of the cocktail that's been used to treat patients in the ICU and even in the hospital. And so we're still continuing to give it as an agent to actually help reduce the inflammation. So as I mentioned earlier, inflammation was the big culprit. And so hydroxychloroquine has some anti-inflammatory effects, which is why they're trying it and still using it. I forgot to mention on my slide an antibiotic called Zithromax. Zithromax is a macrolide antibiotic. It actually has some anti-inflammatory effects, which is again a reason why they're using that cocktail of hydroxychloroquine and Zithromax in severe cases to try to help reduce the inflammatory response that's occurring in the COVID-19 patients. Okay, and then of course there's mechanical ventilation, being on the vent. And for some of you who may or may not have heard of this, there's something called extracorporeal membrane oxygenation, ECMO for short in the medical community. And what that actually entails is we actually do a bypass surgery where we take the blood coming out of your heart, pump it to an outside lung, and then pump it back to the artery that would feed the blood to the heart. So we're kind of like doing a bypass, bypassing the lung to some degree, because the lungs in patients with severe COVID-19, they develop something called ARDS. Okay, so acute respiratory distress syndrome. So literally what it is the patients are actually drowning in their own secretions. Okay, and so they tend to also have low blood pressure. So the treatment for low blood pressure is to actually give fluid. The treatment for drowning or excess fluid in the lungs is to withhold fluid. So it makes it difficult for us to treat patients with ARDS due to COVID-19 because it's hard to balance the fluid that we have to give them to maintain blood pressure, but at the same time not adding additional fluid that can cause them to continue to drown. And so the extracorporeal membrane oxygenation, really, we just bypass the lungs altogether, oxygenate your blood for you, put it back into circulation. And all that does is it just buys the patient time to allow for that inflammation and the fluid inside their lungs to kind of resolve on its own. So that's all it does. It just buys us time. It's not an actual cure, okay? So at the end of the day, we still think prevention is more effective than having to treat you. And so I want to reiterate, practice good hand hygiene, hand washing, minimize touching your face, face covering when you're in public and with others, and then boost your immune system. So what do we do for immune system boosting? Get plenty of rest, balanced diet. Fruits and vegetables have plenty of vitamins and minerals that are beneficial for the immune system. Stay physically fit with regular exercise. There's no more excuse to stay home. You know, there's no shelter-at-home orders at this point in time, and so you should go out as much as possible, or continue to do your exercise routine at home if you already do so. Okay. As I mentioned earlier, smoking. I didn't mention that as one of the higher risk factors. COPD and asthma are one of the risk factors, but the ones I mentioned in the beginning are actually the ones that have higher risk, which is why I mentioned it. But smoking, tobacco, you're just harming your lungs, makes the lungs more susceptible to any infection, not just COVID-19. Laughter has been shown to improve the immune system. So laughter is the best medicine. So light heart, high spirits, those are all something to have. Stress reduction, meditation, prayer. I do both, and I recommend that if you already have a spiritual life, continue with your spiritual practices and stay connected with the Lord. I'm Christian, so I'm going to profess, stay in touch with Jesus Christ, our Savior, and those will all help reduce your stress. Vitamin C and vitamin D, over-the-counter vitamins, readily available, proven to help in the immune system. Okay, so the final thoughts. When we have herd immunity, so it's not a matter of if, it's going to be a matter of when. Whether we get it through vaccines or whether we just let the virus essentially continue to infect people as they may, reducing the rate, but it's going to happen. The mortality rate and the infection rate when we have herd immunity will likely be lower than it is now. Okay? With herd immunity, there will be less susceptible hosts for the COVID-19 or the SARS-CoV-2 virus to infect. Therefore, there's less people that are infected, less people that are contagious, less risk for you to getting an infection. Okay, so less susceptible host means less infections. Less infections mean less deaths. So with that said, we have some questions from our staff here at Affinity Home Health. We are practicing good social distancing. We're a good 8 to maybe 7 to 8 feet away, at least 6 feet for sure. So with that said, I'm just going to go to the questions. So who wants to go first?
Doctor, so one of the questions is, Doctor, should healthy people wear masks? And what is the benefit continuing to wear a mask when a lot of it has been lifted, the mandate has been lifted in a lot of counties? But should healthy people continue to wear their masks?
Okay, so should healthy people continue to wear their mask? So my opinion is yes. All right. So, but I'm going to qualify that response. So, the masks are designed to protect other people. It's not going to protect you, the wearer. So, surgical masks or cloth coverings, these will not stop you from breathing in any droplets that may contain the SARS-CoV-2 virus. Okay. The main reason for these is so that when I'm talking, when I'm breathing, when I'm sneezing, I don't create droplets that can potentially contaminate surfaces or other people. Okay, so as a person who cares for the safety of others, okay, so let's just say others being your family who you don't live with in the same home at least, it would still be a reasonable precaution to take in order to help reduce the risk that you cause for other people who are near you. So now, the qualification I want to put is this. I'm not wearing a mask, and I'm here in the same room with other staff members. I think the best qualification to say is if you cannot maintain a safe distance of at least 6 feet, you got to go to these, okay? But if you're able to maintain the social distancing, then the risks that I pose to other individuals is very minimal. So I wouldn't push so far to actually wear the mask. Okay. There is some comments I've heard though regarding the immune system and staying healthy and having to be exposed to other bacteria and organisms to kind of keep it on its toes. My only, I guess, comment to that is if there are individuals who I know I will come into regular contact with, so people at work, other family members who may live elsewhere, those places I would probably, when we first come to each other, probably wear a mask, but it would actually be a good maybe consideration to slowly reduce how much of these you're doing, mainly because if they're otherwise healthy, I would prefer that they have their immune system ready to deal with anything that I might bring them. And so the only way they'll be ready for that is to get exposed potentially in smaller doses. So you don't want to get one large exposure of a whole bunch of bacteria or viruses at once. We want maybe a small, slow exposure, similar to what we do with the vaccines, where we give you a small amount, but not enough to kind of cause harm, but enough so that the immune system will notice it, react to it, and potentially create some immunity against whatever it is that they were exposed to. Okay, so that's the answer to these. I think at the end of the day, you would be doing yourself a community service by wearing them, and it's not to protect you; it's to protect others. Okay.
And how about when it comes to wearing plastic gloves? Because I know that there's some questions about cross-contamination, or is it simply easier just to wash your hands?
So wearing gloves. So we know that surfaces can be exposed and contaminated with not just the coronavirus or SARS-CoV-2, but other viruses and other bacteria. And so the best approach is proper hand hygiene, and whether that entails actually washing with water and soap to kind of just eliminate the viruses that are on your skin, and if they're not available, a alcohol-based hand sanitizer is sufficient to deactivate viruses and bacteria. So for the individuals who wear gloves, I think it's not anything wrong to continue wearing them if you're going out in public shopping. I know I see them When I go to Costco or some other stores, I see individuals wearing gloves. That's a reasonable precaution if they feel that they need to do that. But I think at the end of the day, even if your hands are contaminated, as long as you don't do this or anything like that, so stay off of this area with contaminated hands, and the gloves are not really doing any service but just minimizing your need to maybe wash your hands. Although we still recommend washing your hands even if you use gloves. Okay, so but I think the proper use of gloves are when it's visibly soiled, or you know you're going to come into contact with bodily fluids or other contaminated items that are heavily contaminated or soiled. It's just a good way to make sure you minimize how much you get on your hands, but also it's a good way to make sure potentially as a protection from skin breakdown, cuts, scrapes that you may get while you're touching those surfaces. And so there's a time and a place for it, but it's not generally mandated if you're not going to be kind of touching any other person that is sick or otherwise potentially infectious.
Thank you, Doctor.
Okay.
And Doctor, now with the phase opening, with restaurants and everything starting to open now, are screening checklists really working, or are they not useful? I know they're doing screening checklists, they're, taking people's temperature. What about an asymptomatic person that comes into these areas? Can they unknowingly, spread the virus, or?
Yeah, so let's start off with asymptomatic unknowing patients. So yes, the individuals who have been exposed and are actually going to be infected with symptoms but are in the pre-symptomatic phases, again, those are the ones that are more likely to be contagious. And so do we know that the screening works? And I think to some degree it's going to be hard to say whether those works or not. However, the fact that they're taking your name when you go in and your temperature, for us will permit them to do what we call contact tracing. So I think the most important information they get from those screening is your contact info, for two reasons. One, if we happen to have somebody in the building that you have come into contact with, we can notify you. Or if the person that you came into contact with, should you develop symptoms and get sick, we kind of know, the exposure that has occurred to other people that you were around during your pre-symptomatic stage. But I think the best and most effective way to possibly screen, the easiest way and I think the most effective are temperature screening for sure, because we know that fevers are one of the kind of the symptoms of COVID-19, but I think it's more likely to denote a more severe illness if you have fever. So that's why temperature is one. But I also think, and they're not doing it at all places. In fact, I don't even think they're doing it at all at the nursing homes that I've gone to. But one thing to consider is probably doing a pulse ox. Okay, so actually checking your oxygen level. And you don't need the medical grade device for that. Most of the smartphones, iPhones, any of these Samsungs have sensors that can actually, you can download an app, you put your finger on the camera or one of the sensor screens, and it'll actually give you an estimate of what your oxygen levels are. But that's actually, I think, a more effective way, because remember, it causes problems for the lungs. When your lungs have problems, you may not be getting enough oxygen in your blood. So you may feel short of breath, but you may not have fever. So if we can catch both the fever and the hypoxia, I think it catches a broader segment of people who may actually have the disease before it actually gets worse. But so I can't say whether it's working or not. I think at the end of the day, it's just good practice to have that information for contact tracing purposes.
And what about in our assisted living communities as well as our skilled nursing facilities? These patients and residents have been isolated from family and friends, pretty much the outside world, for a couple of months or so at least. And then there are some concerns regarding potential psychiatric help or needing either some psychosocial. So what signs and symptoms should we or even should the facility staff be looking for to say, okay, maybe this person needs help for depression or potential?
Well, very good question, because I've had to deal with that already. So I think that the simplest, there's not really even a screening. You just ask, how are you? Are you feeling sad? Do you miss your family? Very common questions. At least just a courteous thing to ask if you just want to make conversation. But if you're caring for the patients, those are legitimate questions that need to be asked and answered. And so the screening is, how are you doing? Is this affecting you? Do you miss your family? That's what I use when I see my patients. And if they say yes, then obviously that needs to be addressed. The other thing you can screen for, if there maybe individuals that are maybe have dementia and really can't kind of give you quite the answer you want, any change in their baseline behavior is a good enough reason to assess whether they're having some psychiatric issue or some medical issue that needs to be evaluated and treated. So the treatments for those, unfortunately, we can't just readily bring family members into the facility, but I think the facilities are, with the opening and the reopening phase, they're a little bit more willing to maybe make some accommodations for those individuals. So if a physician or other healthcare provider determines that the patient has some depression or what we call dysthymia, so a little bit short of depression, we can potentially arrange for FaceTime communication if they don't have the technology or the device to use. And then I've had a patient whose family member, whose daughter was actually allowed to come into the building for a short time. They had a chance to see each other face to face, and then it was a brief visit, but at least it perked up the patient's spirits and mood. So, but those are, I think very important. We're going to see more of those as this continues, and we need to be ready to look for it, assess it, and treat it.
So a lot of these facilities, doctor, are not allowing home health into these facilities, only hospice. So that was our question, was why should home health, nursing, and physical therapy, they really should be allowed in these facilities given the benefit to the residents and protecting the patients and the staff. Moving forward, what protocol can we put into place to move forward with these home health benefits?
Well, that one I can't. Let me just try to find the right words here. Healthcare is a critical infrastructure as defined by the state. It was not shut down when the shelter-at-home order was placed, and so specifically with the skilled nursing facilities, so the nursing homes, they were given the decision or the prerogative to decide whether they should have outside healthcare providers come into their facilities or not. And at least the buildings I go to, none of them have restricted hospice or physicians or other healthcare related workers. So the ones that do x-rays, blood draws, those were not restricted. Optometry and dentists, which normally go there, those professions decided to not go there themselves. They weren't restricted from going. As a medical physician, I'm still seeing patients at the nursing home. So I cannot say what the rules or regulations were or the prerogatives that were given to the assisted living facilities, but I believe if a physician orders a home health nurse or services, that right there needs to be permitted and allowed, because if you do not, it's in my opinion that you're actually preventing the patient from receiving medical care and services, which is deemed to be necessary by a physician. And so if there's an order for that, I believe it should be acknowledged and the visit should be allowed. Granted, the facility has the right to protect the other members of the community. And so the usual screening process and protocols that nursing homes are doing, those are appropriate, those can be done, and you can identify individuals who are more likely to be potentially infected with COVID-19. So that's one thing that they can do. Contact tracing, so they need to just get the same information that we're getting at the nursing home, so the name, contact information, nature of the visit for those home health care nurses, therapists, and other providers. But I think to alleviate maybe the biggest concern that the assisted living facilities may have, they may need to just designate a space within the facility where the outside care provider is restricted to, and then it would be the individual patients who need to be seen that will come in to that room, particularly for the services that they need. And you know, it's a assisted living, so it's considered a home, group home, and therefore the patients should be mobile within the facility anyways. And so rather than having the care provider from the outside traversing the common areas, they should just be kind of ushered to a designated room or location within the community where they can provide the care and services that need to be given for the patient. But that's reasonable. It reduces the risks to everyone, and I think it should be something that should be done. But you know, I would be concerned about restricting access to healthcare workers whose orders were received from a physician to care for a particular patient, because then it puts you in a different type of liability. But the patients can say, I got sick because you did not permit for me to receive medical care. You withheld critical services for my health. And so that's a different liability you have to look for. I think in general, the community and the sentiment right now is that we will not blame anybody for getting the COVID-19 in your establishment. Okay, it's not a matter of when, or not a matter of if, but a matter of when. Pretty much every public place is going to have some person that has had COVID-19 at one point or another, and so the likelihood is that you probably have more liability withholding care than allowing it to happen.
Thank you. Thank you so much,
Okay.
Dr. Luther Mangoba.
Thank
We
you.
appreciate it. And last remarks, or
Yes, last remarks. I think you guys had one more question regarding the masks and orders. So I think that was in your first question, but I'm going to address it kind of separately. So each state has been given the prerogative to decide if they require or recommend face masks. And then within each state, they've actually, at least here in California, they've given the authority and the final decision to the individual counties, okay? And so as far as I am aware, in the county of Riverside and San Bernardino, face masks are not required for the general public. So it means if I were to go out to the store or to a public place, I'm not actually required to wear a face mask. However, the county did allow for each establishment to decide on their own what they deem is safe for their workers. So we're ordered to protect our workers, okay? And so if that order to protect your workers stands and that business decides they want masks on patrons, clients, patients, whatever that come into their public space, then it's up to you to comply or not, and it's up to them to
allow you in.
To allow you in, exactly. So, so if they say, you know what, no mask, no service, they're within their right, and you can't go sue them for not serving you or providing whatever it is that you want. So So they have the authority to decide who they will serve based on what they feel is necessary to protect their employees' health. So in my office, we're all wearing masks when we see patients. It doesn't have to be the N95, it's just the usual. In fact, my staff have their own fancy face coverings, okay? And we have face shields for them as well, but we also still require our patients who come into the office premises to actually wear a face covering of some type. The only exemptions to the face covering are actually kids 2 years or younger. Okay, we don't want them suffocating. They may not comply. It may just cause more of an issue. So they're not required to wear a mask if they're 2 years or younger. So when we have kids coming in for their vaccines in my office, I don't expect to see them wearing masks if they're, if they're toddlers essentially. Maybe 3 or 4 years old. If they're old enough to comply, we'll make it. But for sure, babies aren't required to have it. Okay. And then in the city, or not in the city, in the county of Los Angeles and I think San Diego, they're still requiring it, even for the general public. So you as a citizen in that county, whether you go out in public or not, it's not an option. You're required to wear it. And then I believe in Orange County, they're requiring businesses actually to have masks. So they're not requiring the public to wear masks when they go in. They just require that the employees in those businesses to actually be wearing masks. So the rules are all kind of all over the place. You'll have to check with your local municipality. So the county public health department website is the first place to go to. And then even then, certain cities within each counties, if they implement a more strict rule, the counties are allowing it. So whichever has the strictest level of requirement is going to stand in the city, in the county, and even in the state. So wherever you're traveling, just be aware you may have different laws that you're having to deal with, and plenty of people travel across counties nowadays, and so it is what it is. All right, anything else?
Okay.
No, I just had one last question. So all of our clinicians, our nurses, our therapists, occupational therapists, speech therapists, as well as our caregivers, they're all wearing the PPEs. They're all wearing the protective equipment when they're entering facilities. And in some facilities, they do have a designated room, just like you suggested, where that's where you see your patient. So with the PPEs and having that designated room, that should be enough as far as bringing that virus into the building. 'Cause that's what they're worried about.
Right. So the PPEs, they work both ways. So they keep me from anything that's potentially on my surfaces from contaminating any new surfaces I go to. But it also, at the time when you take off the PPE, you're leaving behind any contamination that you may have gotten while you're at that building, and you're leaving it there. And so you're not going to track it out of the facility and then maybe bring it to your next location. So yes, wearing a PPE is good for protecting the individual wearer, but it also helps reduce what they bring into their next location. So if you happen to be the first place that caregiver or health provider goes to, if you're just wearing your usual clothes and then you go into the next building with the same clothes, then yes, you may be carrying it. But if you're wearing protective equipment at each location, then you're reducing how much you pick up and how much you bring to the next location. And in fact, that's one of the questions that they actually ask at one of the nursing homes that I go to. Okay, so not all of them ask it. They're all catching on that they should be asking it, but they do ask, have you been at any other healthcare facility prior to coming to our building? And if you have, they either will provide you a gown, or if you're an employee, they'll require you to switch to clean scrubs or a new set of clothes that are fresh for that location. So whatever it may be on your clothing, you won't be tracking. Now, in terms of how long viruses last on clothes or fabric, if it's if it's a loose or breathable fabric, probably no more than 3 to 4 hours. Okay, that's because the fabric will absorb the droplets that contain the virus, and it dries out. And when it dries out, that potentially essentially just reduces, even if the virus is still alive, it reduces the likelihood of being breathed in and then entering your respiratory tract. But certain clothes that aren't breathable, so like Gore-Tex or some of the waterproof stuff, those if you're wearing it, they can last maybe even a good day, because if the surface doesn't dry out, the droplets remain somewhat moist, the viruses remain viable, they can still get picked up and then transmitted. But again, the key way that surfaces will infect others is if somebody touches them and then they subsequently touch their face before they actually wash their hands. And so to protect yourself, really, just if you touch anything, don't touch your face before you wash your hands, and that way you minimize carrying the virus physically to surfaces that will actually allow it to gain entry into your body. So, and I think, is there any other questions?
Yeah, okay.
All right, so those are all good questions. Hopefully we were able to answer them and alleviate some fears and concerns. In the meantime, just continue to practice good hand hygiene, continue to be patient, care for other people, and make sure that you help protect them by wearing these, even if you're not required to, and continue to pray.
Thank you.
All right.
Thank you very much, Doctor.